we are running late, so I'm gonna move hopefully a little bit faster. So good morning for anybody who doesn't know me, probably should. My name is Sharland Johnson. I was one of your chiefs. And today I am giving a lecture on weather and the ED. It's an examination of meteorological phenomena and their effects in the emergency department. Basically, what I'm talking about is black clouds, right? So really, for me, I don't think black clouds exist. I think really what they are is a way for your class to just horribly make fun of you for 4 years and just constantly harass you. And so as they harass and abuse me, I was like, you know what? I'm gonna do a study on this. I'm gonna prove they don't exist. And then yesterday in CCT, after the shoulder dislocation that had a vascular compromise that became a level 1, after the intubation, while I was transferring the STEMI code, I was like, even though this is obviously fake news, maybe I'll switch my topic just a little bit. So instead, I'm going to use this time and my last time, really, because I think I am the last senior lecturer of the year. And we're going to talk about the tales of a black cloud. So learning points in the creation of a clinical monster, right? I'm going to go through a couple clinical cases and basically just talk about things that I've learned that I think County has taught me and that I want to keep over the course of the last 4 years. So we're going to start on the topic of the emergency department as the great equalizer. So one of my first cases, intern year, you know, the beginning of the year when you still can't really introduce yourself as a doctor, and every time they say doctor overhead, you're kind of freaking out. Yeah. Chief complaint for this patient was my feet hurt and I have a rash on my penis. And I was like, okay, I got this. These were his vitals. This was pre-COVID. That 99.2 didn't really ring a bell. So I get up and I go to see the patient. He's in, what is that, room 17 in the corner, like by himself. He's 62. He has no past medical history. When I walk into the room and I see him, he's dressed in multiple layers. Now this is August. He's wearing about a shirt, a sweater, a jacket over it. He has like 2 pants on. He has shoes and socks on, okay? This gentleman is homeless. He doesn't smell all that great. And I'm pretty sure in the early days of County, they brought him into the room, they closed the door, they didn't want that smell getting anywhere, and they left him in there. So I go in and I'm talking to him and he tells me that he has this rash that started on his genitals, his feet hurt, but he hasn't really looked at them in a couple of days, but the last time he saw his feet, they looked fine. The one thing I have learned in like my 2 weeks of residency is that when someone tells you it hurts somewhere, you should probably look at it. So I take off his shoes and that's what happened. So upon complete disrobance of the patient, he's found to have a desquamating rash all over his chest, along his genitals, along his lips, in his mouth. He has conjunctival injection. When I take off his other shoe, the same thing happens. And his rectal temperature is notable for a fever, 100.6. So baby intern Shar is now freaking out. But I had a good attending and a good senior who walked me through my diagnosis of TEN. This gentleman was eventually transferred to a burn center. Now, we are all pretty familiar with the almost quarterly M&Ms that we have here of the intoxicated or homeless patient that comes into the ED, who probably doesn't get evaluated or examined as clearly as we should, and they have a poor outcome. The reasons why these M&Ms are so common is that these patients are parts of a vulnerable population and require special attention, not only due to their circumstances, but because of our own biases. So these vulnerable populations, these are social groups whose members have increased morbidity and mortality and risks secondary to factors such as low economic status and or environmental resources. These populations include not only those with substance abuse issues and the homeless, but also the elderly, racial and sexual minorities, patients with mental health disorders. The emergency department should always be the great equalizer. Everyone that comes in the door should get a thorough examination and you should take a good look at them. You should be especially mindful of your own biases. This is because as the emergency department exists, we are a medical and social safety net. So, but we know that's not always the case, right? And the data bears that out. There have been several studies looking at health disparities within the emergency department and within medicine in general. And looking at vulnerable populations, we'll see this over and over again. A study of data taken from the National Hospital Ambulatory Medical Survey, that's a mouthful I know, between 2005 and 2016, which is administered by basically a subset of the CDC, found that African-American patients are 10% less likely than other races to receive urgent ESI scores upon triage in the emergency department. They're also 16% less likely to get imaging and 4% less likely to have any blood tests done. When we talk about the homeless patients that we take care of, homeless individuals have mortality rates 3 to 6 times those of the general population, even when coordinating and confounding for risk factors, right? So this is an independent risk factor for their mortality. In 2017, a joint poll was conducted by the Robert Wood Johnson Foundation and the Harvard School of Public Health. And in that year, they found that 18% of LGBTQ individuals had avoided seeking medical care for fear of discrimination. So these patients are at risk because of their socioeconomic status and because of what's happening in their lives. And then we are confounding that issue. So, but all of these different issues, and kind of piggybacking off of what Noah's talk was on earlier today, these are also clinical problems, right? In medical school, we talked about social determinants of health and how people's environment and their social status determine some of their health outcomes. But even more than that, we should think about these different factors make this population vulnerable also affect our differential diagnosis, right? These patients are increased risk of diseases due to fragmented clinical care with no expectation of follow-up, like this patient who was diagnosed with a finger wound and given Bactrim by an outside hospital and sent out with no follow-up. They're at risk for diseases of malnutrition and poor sanitation. They're at increased risk of diseases due to exposure to elements and communicable infections. There is a reason why Kings County still sees so many TB patients. And for our part, it is very important for us to kind of screen for these mental health disparities and substance abuse issues because it will help inform our differential. And it's also important in the population where we see so many immigrants and so many new arrivals to the country to inquire about homeopathic and cultural treatments, which could not only be affecting what they're presenting for, but may actually determine what they're willing to be treated with. So, as some of the ways that we can kind of help prevent this is whenever you go into a room to talk to a patient, assume nothing, question everything. How many times have we seen the patient come in with diabetes and their blood sugars in the 700s, and you're like, but you've been here 3 different times for it, but nobody thought to ask why they are not taking their insulin. You ask why, you figure out, oh, they have visual impairments and they literally can't pull up their insulin. That's why they're not taking it. If you don't ask the questions, you won't get the answers. We should determine your patient's level of understanding and reasoning. Treat all patients as if they're a relative of your best friend, as if they were a family member. Try to relate to your patients on a human level. It will help remind you that you are treating a person and not just a disease. And every patient can teach you something, right? As Dr. Sinnert is fond of saying, more patients, more learning. And as something that we have learned overwhelmingly at our time here, there is a sick person in any room that you're in, and your job is to find them. And if you kind of skip over these patients who are vulnerable, which is another synergism, you will miss these patients. You don't want to miss the sick person in your room. Okay. So now you're a big bad second year. You've got this down. You know what you're doing. So this case is of, this actually wasn't my patient. I was in the front of the pod minding my own business. And I start hearing some like commotion behind me. I get up and go check it out to see a gentleman. He's pretty large guy. He's currently wearing a plastic bag on his genitals and he's covered in feces. He presented to the ED initially because he was found agitated and seemed to be confused. He was worked up in the ED and he was to be transferred for CPAP, and the transfer was already in place. However, as his sedation wore off and he got up, he got very agitated and very aggressive. He started asking for a tray. The nurses didn't want to give him a tray because he needed to be transferred. And then he started wiping feces basically all over. So I go over and I see this. The nurses are kind of yelling at him that he needs to calm down. He picks up a workstation, he flings it across the room. Things are getting kind of concerning. He finally sits down on the nurse's chair, once again, still covered in feces. So at this point, The nurses call hospital police, HPD gets there, HPD refuses to intervene because he's covered in poop. Or the patients around him are starting to get concerned. He's getting more and more aggressive. And at this point, we have to decide what we're gonna do next. Now, on one hand, the simple solution is to try and get HPD to jump on him and sedate him and to do all of this. But what I did was I grabbed a tray and I set at the head of a bed and I said, darling, you want food? I put the tray on the bed. He looked at me, he ran towards me, he jumped onto the bed, face first into the tray of food and was happy. So I tell this story because while it has an amusing end, it could have gone another way, right? We've all been there when it takes multiple providers and HPD officers to kind of hold people down, to sedate them and to restrain them. But this isn't really the direction that we constantly want to go. In a small quantitative study of about 25 individuals conducted at Yale University, most of the patients identified with 3 primary themes. These were people who were restrained in the emergency department, and they noted the experience to be traumatic and harmful experiences. They said that there were a diverse and complex personal context affecting the visits to the ED, and these episodes left them with persisting negative consequences to their well-being, and they ended up with symptoms similar to PTSD. While this is true of our patients, the converse is also true for us, right? So according to the Bureau of Labor and Statistics, those that work in healthcare sector are 3 times as likely to have illness and injury from violence compared to private industries. In a survey of emergency medicine residents working across New York City that was published in WestGev in 2016, 65.6% of residents reported an experience of physical violence by a patient, 96.6% reported verbal harassment from a patient, and 52% reported sexual harassment. So this is an area where our patients can be harmed and we can be harmed. So de-escalation really is the name of the game. This is something that we are going to be doing for the entirety of our practice. So there are a lot of different methods out there that and topics that talk about de-escalation. This is one of the ones that I like mostly because it spells diffuse, and that's basically what we're trying to do. In general, some tidbits to think about when you are trying to de-escalate the situation before you get to the point that you are trying to restrain and sedate this person. Respect the patient's physical space and respect your physical space, right? If you're not close enough to harm, you're in a much safer space. So 2 arms length between you and the patient. Don't be provocative. We've all seen interactions in the ED that degenerate because the patient gets aggressive and the responding individual also gets aggressive with them, okay? It's not just what we say, it's also how we say it. So we have to be mindful of our body language because that is communicating much more than our words are saying. You want to establish good verbal communication with your patient. Identify yourself, identify what your goals are, identify how you want to help them, and have them do the same. What do they want to be called? What brought them in today? How can you help them achieve whatever their goal is? Be concise and caring when speaking to them. Use short sentences, simple vocabulary to get your point across. Give your patients time to respond to you and listen to them when they are talking to you. They're going to talk about what they want, what their feelings are. Listen and respond appropriately. Agree or agree to disagree. Don't lie to your patients. The moment you lie to them and say X or Y can happen and it doesn't, you've permanently damaged that relationship and it's going to be really hard to go back. All that being said, you also have to set clear limits. This is what is acceptable, this is what's not acceptable. If this is done, this will be the consequences. So they know beforehand, and so you can navigate that relationship. Give them tactics so that they can help themselves calm down. If you sit down and talk to us, we can get this done. If you get this x-ray, we can move on. But also try and give them hope for the end of the day. You don't want them to stay in your ED. They don't want to be in your ED. Try and figure out what their goal is and let them know that you are working with them to achieve it. Okay. All right. So now you're a 3rd year. You definitely have this down. You've been here 3 years. You've seen everything. There's nothing left to learn. So this case actually happened at Downstate, and I think most of my class has probably heard about it. So the chief complaint is my stomach hurts. These are the vitals. The patient is known to be hypertensive. She's an older lady, 72. 70 years old. She has no past medical history, but she hasn't seen a doctor in a little while, but she looks great. She runs every day. She came in because she had a little bit of epigastric pain. She's chilling. During the course of my examination, she seems fine, but she's elderly. She has epigastric pain. Her EKG is not particularly impressive, but we work her up as hopefully GERD, but rule out ACS. We send off labs. Everything is chilling. The room is incredibly busy. I move on. I come back to check on her, and her pain's a lot worse. And now she's kind of sweaty and she doesn't look too hot. I go to my attending and I'm like, I think I want to CAT scan her. I don't know what I'm looking for, but I don't feel too hot about this. When we get back to the bedside, the patient is now aphasic. So we called a stroke code. Because it's downstate, the first floor CAT scanner could only do non-con CT, so she got her non-con head CT, which was negative. She's still incredibly hypertensive, so above 200s, and now we are incredibly concerned about the dissection. So we bring her up to the second floor CAT scanner. We CTA her head and neck, and this is what we see. And it just keeps going. So at this point, this patient needs to be transferred. So we get on the phone, we call Maimonides, we let them know that we have a patient that needs to go over. We had only gotten the head and neck, and they asked to complete the rest of the scans. The patient is awake and still kind of aphasic, but doing well, almost improving. Now he's talking to me. We take her back upstairs to get the complete trend studies. And as we are taking her off of the CAT scan table, she codes. This is in the second floor CAT scanner at downstate. There's nothing in there. It's me, the medical student, and the CAT scan tech. Her husband, who is a lovely gentleman, is outside waiting to see what's going on. She codes in the room. We rush her downstairs. I have to tell this lovely man, your wife has just coded. This is not what we expected to happen. We're going to work on her. He is crying. We're trying to save her. We go downstairs and we code her for about 15 to 20 minutes, and she dies. So she walked into the ED that morning talking to me, looking well, and I expected to discharge her. Then I have to explain to her husband why she has died in my department. So I tell this rather sad story to say that you will fail, but you will survive. Albert Wu created the term second victim syndrome to describe the negative experiences, emotions, and trauma that healthcare providers involved in unanticipated adverse patient events, medical errors, or patient-related injuries experience. After this case, I will be honest, I was a mess. I literally went to my co-residents and I was like, I'm just gonna cry, could you pat me? And sometimes that's what we need to do. Everyday healthcare professionals practice within an excessively complex healthcare situations and meet unexpected patient outcomes. Avoiding complications is of course a major goal of all patient safety efforts. However, medical errors and adverse events are a part of medicine and they will happen. You can ask any of the attendings in the room, they will all have multiple cases that stick with them. And after the fact, you're constantly thinking, did I do everything I could have? Could I figure this out sooner? What if I had changed this? What if I had done that? Some of you may recognize this image. It's of a physician that went viral on social media in 2014, I believe. It depicts a grieving EM doc after he lost a 19-year-old. Now, part of the reason why this image went viral is because we very rarely get to see physicians grieve. Something bad happens in the ED and you immediately have to move on. The point of talking about second victim syndrome is that it is a recognized and noted thing that happens in emergency medicine and to all physicians. And it is something that we should watch out for both within ourselves and within our co-residents, within our co-workers, within our classmates. Psychological symptoms of second victim syndrome are anger, irritability, depression, extreme sadness, fear, feeling numb, flashbacks, frustration. These all sound like PTSD, and it is along the lines of an acute stress reaction. In a survey of practicing American and Canadian physicians, 61% said that after they experienced something similar, a bad case, they had anxiety regarding future errors. 44% had loss of confidence. 42% had sleep disturbances. And only 10% of doctors felt these institutions supported them adequately. I say this, as I said, to remind us that we have to practice medicine with compassion, not just for our patients, but with compassion for ourselves. Bad things will happen. We will have to deal with it, and we will have to move on. Okay. So now that I have said something to depress you, I will end on something not quite as sad. So know when to hold them and when to fold them. I like this quote mostly because it's talking about knowing your limits. The day I'm about to tell you about technically happened when I was an intern, but I don't think I understood what my senior was doing until I became a senior myself. So imagine you walk into CCT, and as you walk in, you get ready to round. Near the end of rounds, the nurse comes and says, 2 of the patients in those 2 rooms are kind of looking crappy. Can you come look at them? You go and you examine both of them, and they are both impending respiratory arrest. So you're like, okay, we're gonna get ready to intubate them. You get everything set up, you move into the first room. As you're intubating that patient, a level 1 trauma comes in, that's a stab wound to the chest, and they need a chest tube. So you have to now manage that with the 2 intubations that you need to do. When you're finally trying to calm down from that, cardiac arrest comes in that needs to be intubated and needs a central line. So now you're managing these 3 patients and the cardiac arrest. And to round out your lovely first 4 hours of shift, you get an elderly woman coming in incredibly septic, altered to kypnic to like 40, that eventually does require an intubation. Sorry. So some of this, basically what I'm going to talk about is management strategies. Hannah just talked a lot about this as well. So it's just a quick recap, basically. Or emergency department is lucky enough to be divided that you have a critical care section and the regular pod that we talk about, where you see not as critical patients. So I'm going to talk about management strategies in the critical area. So first and foremost, avoid investigations that are better done elsewhere. Can this patient be cleared? Can this patient be discharged? Can this patient follow up at home? Part of what you're doing when you're managing a room is decompression, figuring out who needs to be there. My second little tidbit is don't order tests or studies that will not or should not affect patient management. Do not open a can of worms that you do not want to know about. In the first place, ask yourself constantly, how will this test change the patient's management or disposition? As Hannah was talking about before, have a task priority list. For me, when I'm in the ED, especially in CCT, the things that go first, interventions that are life or limb saving come first and should be completed before you tick them off of either your mental or physical list. If you intubate somebody, they need an OG tube, they need an X-ray to confirm placement. The intubation is not complete until those things happen. Stabilization procedures come next. Does this person not have a line? Are you not able to get a line? Do you need a central line? This is where you go to next. Require tests or studies that are going to change disposition come after that. Consults come third. When you call your consults, let them know what your question is, but also let them know what your timeline is. I want to know what's going on. This patient has been active in the ED for 4 hours. Please, can you get back to me within 2 hours? Thank you. Anticipate outcomes and issues before they pop up. You know when you're gonna call the medical admitting attending and he's gonna give you pushback because he wants cardiology to pass by the patient. So if you know that's coming, jump ahead of it. Plan your procedures. There will be days both in CCT and in the pod where you have multiple procedures. Don't leave the LP for the last 20 minutes of the day because it's going to be an easy LP, because that will be the hardest LP that you will ever do in your life. And especially for the seniors, something I know we struggle with is delegation. You don't have to do everything yourself. Find the person in the room that is best suited to the task. Sometimes that is your junior, sometimes that is your nurses, sometimes that is your attendings. Let them know what you want to have happen. Delegate the tasks that don't need to be on your plate. But as I said, a busy room isn't always in CCT. We have terribly, terribly busy days in the pod as well. A lot of these same management techniques do apply. I'm mentioning Dr. Wiener's his like task list. Most of us probably get this task list sometime during intern year. And in order, it goes resuscitation, stabilization of unstable patients, pain control, discharge home, admission, all other stuff. And that's how you're going through, that's how you're moving your room. Of course, you have to remember, when these things don't work, ask for help. Nobody is going to be looking at you saying, oh, well, you know, the room was busy and she didn't manage it herself. They're gonna come in, they're gonna offer you help. Know who is able to help you. Know when you can go and be like, you know, you're in peds and you're not that busy, come help me out. Okay, I hope I did not speak too quickly going through this because I'm trying to make up some time. But those are my 4 years of like learning things, turning into a clinical monster, hopefully. And because y'all made me go last, I'm gonna make us cry. This is my goal. This is my goal. Okay, so these are my thank yous. First and foremost, this is my fiance. I feel like most people here have heard about him and probably think I'm super mean to him, but I have proof. I like him. It's proof. They say it takes a village to raise a child, and I am still a child being raised. These 4 women have done as much to raise me as almost anybody else in my life, save for this woman who I feel like you've all heard about as well. This is my mom. And I would not have made it to the end of residency, much less to my 30 years of life without her. And then lastly, I would like to thank my class, who have kept me alive and sane mostly for the last few years. We have gone through the beginnings of times, we have gone through fun times together, we have had many sleepy times together, we even had Zoom times together, we've had some breakfast times, and now we are at the end times. I will miss you all dearly. But if you miss me, just remember you're still in Brooklyn and everybody sounds like me and everything going to be Irie, all right? I would like to thank Dr. Wiener, who I accosted on his DCT shift yesterday to give me his printout, Dr. Sinner, because we need synergisms in our life, and Dr. Hassel and Dr. Willis. And these are my many credits.
Very nice.